Giving you permission.
Just
Today we have Sam Albani, who's going to talk about periprosthetic fractures around the hip. Again, a very important webinar question, and I know Sam very well from our previous time we studied together. I'm very sure he's going to give us a really excellent presentation.
hello guys. So this is about the periprosthetic fracture, which a question that thank you, Sean, first. Sorry, just went directly. This is about more. It can go anywhere. It can come in your basic science. It can come in your pathology, and it can come in your trauma. So be careful why you are approaching this question, because actually this question can cover everything, and you should really concentrate on how you're going to assess the patient, because there is no wrong, but there are principles. So I will try here to go through the principles quickly. Hopefully this will be solidified, and then you build on it. You pick what you want while you are going through the question. So this is my disclaimer, no interest. My only interest is to make everybody pass this exam, and it is not that difficult, just needs to know the tricks. So to save time, so periprosthetic fracture pose unique fixation challenges. And usually you will find these are frail patients. So always when you are faced with a question like this, think about MDT, orthogeriatrician. Discuss with a colleague who's expert in hip, because you can be consultant on call and then you just get this. There is no hurry. There is no hurry. It just, this needs to really be well planned, and all the options should be explored, and everything should be on the shelf. Okay. And recent studies showed that cemented implants are safer, either intraoperative or postoperative. So the number of implants in the femur are increasing. We are doing more total hip. Population are aging, joint replacement are indicated more often, and then you can even connect this to the NICE guidelines. They are now having very low threshold to put a total hip replacement in fracture femur. If a patient just can go out of their house with a stick and can go to do their grocery independently, then they should receive a total hip replacement. And the fracture fixation itself is indicated more often around the implants. So as the number of implants placed increase, the number of associated fracture will increase. Yeah, logic. Okay. The problem with the high mortality, with the fracture after around an implant, it carries a high mortality. You just imagine that you put this hip in already elderly patient, and they maybe for 10, 15 years are going on, and then they will fall and sustain the fracture. And then you have to do something. This is frail patient, and you have to really assess this patient and optimize. So as I've been told before in my exam, be safe. Stay in the safe zone as much as you can. And especially for the international colleagues and the non-trainees, we are expert enough to just jump into, okay, this is what I will do. No, this is not about this exam. It's not about the UK. UK, they have a system that you can ask, you can refer, everything. But they want to know that you will be safe. You will assess the patient well. You will explore everything. You will ask everybody. But when you answer like this, also balance it. You will not say, no, I will call everybody in the ward, but I need to discuss, this patient need to be optimized and move quickly, but the principles are. The study showed again that the mortality after periprosthetic fracture is about 11% first year. And actually, it is similar to mortality following neck of femur fracture. So if we are very, very fuzzy about the fracture of the neck of femur and we should take it within 36 hours and all these things, we should also know that it is the same mortality rate after periprosthetic fracture. So it is, again, it is a payoff. I have to optimize the patient. I have to be ready with everything, plan well, but I should do it as soon as possible. And ideally within 3 to 5 days maximum. Planning, as I said, is very important. Okay. So, and planning, there are softwares, there are many things, but the planning usually after assessing the patient, we start with classification. And we will discuss the classification quickly because all the management actually depends on the classification more or less. And then, as I told you, templating, which is just that software. There are TraumaCAD. We use TraumaCAD in our trust, and it's very helpful. And there is a section on it just for the periprosthetic fracture. And then you have to have everything on shelf. You have to have everything. Be ready. Be ready with revision. Be ready with the plates. Be ready with different screws. Be ready with the cables, with the circlage. You might need to remove the cement. You might need bone graft. All these, be ready with. So as I said, be prepared. And there are specialized implants that you might need. Some of them only for revision, like the metaphyseal fixation implants, like the, as I said before, the proximal replacement, femur proximal replacement. Maybe there will be something on the acetabulum. You need to be ready with all these things. So when you are discussing in your exam, just show him that you know that I will not open the patient and then get stuck. I need to be ready with everything. I will think and think and think about what I may use before I go to this. It is not an easy decision, not an easy surgery. Most of the things is claw plates, cable, maybe the screws are broken, maybe it's fixed before, so broken screws removal, and implant removal and cement removal, all this, if it's cemented, all this, you need to be on shelf. Okay, so now classification, and I'm sure that all of you know it more than me. This is the most common classification, and there is a very, very famous paper. And I remember one of my colleagues who passed before me, and he told me his 8-mark question that he asked him, do you know who wrote this paper? And I think Duncan and Masri, that's who wrote this. Anyway, so Vancouver classification, we all know ABC, and surprisingly there are more. But anyway, A, it is just the trochanter. So AL is the lesser trochanter, AG is the greater trochanter. And this is the paper that I'm telling you about. It's Duncan CP and Masri PA, fracture of the femurs after hip replacement. So B1, then we will come to B. So we know A, and then we come to B. And most of the X-rays that you will be faced with will be type B. And when you are faced with this type B fracture, which is generally speaking, it is around the implant, down to the tip of the implant, then it is just few things. You know this is B fracture. So it is not, it's one sentence you have to say. This is a fracture around the implant. It makes it B, but I need to assess the loosening of implant and the bone stock. The loosening of implants, even if you see it is very clear, this is at the end is an intraoperative decision. So I would classify it B2 until proven otherwise. And you look carefully. If the bone stock is not good, then say C. Okay? And be careful, I'm writing, be careful about the tip fracture. Because the tip fracture is very, you will see later on, the tip fracture is very special, especially if it is low, short oblique, or if it is transverse. Because although maybe it is still B1, the implant is well fixed, but the fixation results are not good due to biomechanical reason. The healing is not good, a high risk of non-union. So be careful if you saw an X-ray like this one, which is more or less around the tip and it's short oblique. Be careful about this. B2, fracture around or just below a loose stem. So the buzzword is a loose stem. And you can see it or you can assess it intraoperatively. If it is very clear, then this is B2, and then I'm looking for the bone stock. It is B2 or B3. Sorry, it's not C. B2 or B3. And if it is not very clear, then as we said, it's B2 until proven otherwise. B3, structures around or just below a stem with poor proximal femoral bone stock. Then I'm thinking now how I'm gonna compensate for this bone loss, which can be either trying to augment it or just discard it and think about other things, how I'm gonna go, maybe metaphyseal, maybe diaphyseal fixed implants, and just forget about this proximal femur part. And then the challenge of the version and how I will know what's my version, more or less, if I don't have any greater tuberosity, I don't have, it's just rounded medulla. Type C, fracture well below the stem. Okay. And again, as I said, always take it to the basic science, always take it to the basic science. So basic science will say, okay, do I have anything down there? So the first question, if he showed you up there only, and he didn't show you the knee, the first question, I want to see an X-ray of the knee to make sure that there is no implant. Is there anything on total knee replacement or anything? Because this will affect my management. Then the examiner will think, yeah, this guy knows what he's talking about. Because he may ask you why, so what? If it is far away. He said, because my implant has to cover whatever fixation I will do, that has to cover both implants. Otherwise, I will create a stress riser. And I can tell you, you passed just by saying this. Surprisingly, I was surprised. I was in a course recently about the management of this, and they introduced this. I didn't know, to be honest, until I passed my exam even, that there is D, which is with knee replacement down there. So C, with a total knee replacement down there, it is D, it's not C, okay? And I think if you said so, you can impress if he really hip surgeon, or if he challenge you, think I just read it, whatever. But this is there. E is you have both the stem and the acetabular fracture, and F is actually when you do hemi. So you have the acetabulum is fracture, but there is a hip hemi arthroplasty over there. So you have to think what you're going to do, because you cannot just put anything over there. Even if you fixed, then maybe it will not be that congruent, and the patient will need replacement or revision after that. So again, the fixation, if you want, just why we don't fix everything. So the fixation, there are a lot of challenges actually, because you have the implant. So how you gonna, what you're gonna do, how you gonna go around it? The implant was there for a long time, so maybe it changed even the structure of the bone. And the implant itself may interfere with healing or the placement of fixation devices, as I said at the beginning. But most importantly, which is not mentioned over here, is it a happy hip or not? You have metal inside already. So it's a very, very important question. Although this is a straightforward, I will just fix it. It's C, no problem. But I have to ask, did you have any problem with your hip before? Did you have any pain before? Because the pain, maybe the implant can suggest implant is loose, can suggest infection, can suggest even a pathological fracture. So it is not, again, I'm emphasizing this is not a simple case that, okay, this is a fracture I will fix. My only challenge is where I will put my screw. Okay? Then when you treat these implants, when you have implants in, so these can block the new fixation devices, as we said. So if you want to put a medullary nail, then this how you're going to put it. And also, as we said, the implants can impair healing because there is an endothelial ischemia. And if in type B3, the bone is not good. So what I'm going to do? All these factors, you should think about it. And once you, in the exam, you just mention it quickly, this is how I will think about it. This is what I will take into account. Then he will know. This is what he wants you to say. He doesn't want you to say just how you're going to fix it. He wants to make sure that you will think with this holistic view about this fracture. So, general rules for the fixation: follow standard principles of fixation, which is restore alignment, stable fixation, and your main aim is to mobilize early, preserve soft tissue attachment, indirect reduction if you can, and when you do it, go long, span the whole femur, because a fracture can happen later on. So span the whole femur. Intraoperatively, as we said, have everything.
We're allowed to record now.
So intraoperatively, be flexible, be creative, and think out of the box. It is not a straightforward case. And choose the device that fits the patient, which means if I have a 90-year-old, it's completely different than 80 years old, completely different than 65 or 70. I should think, while I'm doing this operation, I should think about the next operation actually. What if he got another fracture? What if his implants started to be loose? What if he will need a total knee replacement? What is his demands? All these should be in my thinking while I'm planning for this. It feels like this is a complex, but it is just taking everything into consideration. Take a good history, the expectation of the patient, all these, take it into account. Okay, so let's go quickly about more or less the recommendation, but as we said, it is no one size fits all. I have to assess the patient, but generally speaking, greater trochanter fracture, if it has happened intraoperative, assess the soft tissue attachment. If the soft tissue, the abductors, are well attached and everything, you can either ignore, you can put a circulage wire, but my main concern is not the fracture. My main concern is the soft tissue attachment. If it happened post-operatively, then I will look at the displacement. If it is widely displaced, then I will go and fix because there will be no function. If it is just a little bit or the function is good, then I will leave it and it will heal with fibrous union, and that's okay. And options for fixation, simply circulage wires or glow plate, as you can see over here. Vancouver B, so treatment options. What's the most important factor is the status of the implant, as we said. Is it loose or well fixed? And then next, we will look at the bone stock. So If it is loose or not, it is an intraoperative decision. So as I told you, always say, yeah, I will consider. The best way to say it in one word and one sentence and run away, I'm not sure. It looks fixed, but I'm not sure. So I will be ready and I will treat it as type B2 until prove otherwise. And intraoperatively, I will be ready with everything. Full stop. So that when the implant is stable and well aligned with good quality bone, so it is not B3, consider fixation. But as I said before, be careful about the tip fracture, which is transverse or short oblique, because you can see over here more or less, yeah, this is healed, but this sometimes doesn't heal. And sometimes the stresses are too much on the plate and it will fail again. Okay, so you can put, as I said, plate or allograft. The allograft, you can put it parallel or 90-90. Yeah, it's parallel is more mechanical sound, but at the same time, it is a lot of dissection, which we don't want. Tips for Vancouver B1, which is mainly will be the fixation. As you said, is it happy hip? Because if it's not happy hip, it doesn't matter if it is fixed, not fixed, blah, blah, blah. I need to explore this more. Whatever I put in will not work. Patient already has a problem with this total hip. What are the comorbidities? Will this patient like live for long, live for short? What are the other problems? Do I need a quick operation and just run away? Can I do a lot? All these should I think about. The mobility, if the patient is just sitting on chair bound or just not mobilizing that much, then this might affect the implant option that I will use. The uncemented is challenging. Everybody think, okay, I will stay like 100 years with Oscar to remove the cement, but actually, at least you know what you are doing. And so, and for the cemented, okay, sometimes it looks well on the X-ray. That's why it is B2 until prove otherwise. And you have really, he's saying I had some pain over here, and you are really not sure about the X-ray. Do a CT, because sometimes the cement, there is a cement debonding, which means it doesn't look on the X-ray there is any problem. But when you do the CT, you can see that there is very faint line in between or cracks in the cement itself. Okay, he can ask you then, okay, this is a very tricky question to see if you saw it before or if you did it before and you know what is it. So how are you going to position your patient? So if I'm sure it is B1, I'll just do it supine, no problem, okay? But because I need just to fix this fracture, but if I need to assess and I might revise, then I have to put the patient in the lateral position. So if you can choose to say always lateral, but it will look more like you are thinking. If you are say, if I'm sure I'm just fixing, I like to fix in supine, but if I'm not sure, then I will keep my options open because may I need to revise and I will put him in a lateral position as if I'm doing revision or total hip replacement. Femoral distraction, sometimes you ask, oh, how are you going to align it? I will use femoral distractors. I might need, because I will use long plates, so I need plate benders. Again, transverse and short oblique, just open. It's very difficult to, many opening, because it's very difficult to align it and reduce it. Strut graft, as I said, 90-90. Proximal plate, just fix it with cables or put para stem screws. And you can again say this, the cement is always stronger than the bone in this group. Okay.
10 minutes.
Plate holes are opportunities, not necessities. Respect soft tissue and go long, as we said, from the greater trochanter to condyles, because these group of patients are frequent fallers. If the implant is loose or malaligned, so consider revision or replacement. And in revision, avoid potential difficulty of fixation. That this is the advantage of it, because you don't have to think about all these fixation things, and you don't have to think about the malunion and non-union, okay? And definitely, if there is poor bone quality, then you need to think about revision and bone grafting together, or other options as we mentioned before. Type C, just think it is really C or D. So always ask for the X-ray of the knee, and again think about, he might show you an X-ray like this, okay? He's showing you the knee, but maybe that implant is loose. So I will not fix it, just fix it. Either fix it and then revise it, or consider one operation if the patient is not, he cannot get into many anesthetic and many operations. And as we said, just treat it as any fracture, but be aware of the stress risers. Okay, this is some papers about, or some tricks, if you want to say, if you are now scoring 8, so combined allograft and struts and plates, there's the mechanical use of allograft with plates has found to be stronger. These are the recent clinical studies, still controversial. Is plate fixation alone is enough, or you have to use strut graft? Cables, extensive exposure, and are technically demanding. So the fewer use, the better, but achieve your mechanical stability. Don't put everything. These are papers again, many of them, but none of these address the question how many you should put. These are other papers. Using of some screws with the cables will improve your rotation stability, so use combination. And these some examples. So quickly, how much time left, Sean?
I think we've probably about 9 minutes, I think. Sorry,
Okay.
time has just come up.
Yeah. So 82-year-old female with pre-existing loose hip replacement. She fell, sustained periprosthetic femur shaft fracture. X-rays finding, you can see there is osteolysis and there is subsidence. You can see there is subsidence. The cement was up there, okay? So this is a treatment they choose, okay? Prosthesis removal, strut medial allograft, and long stem femur revision. How long? We all know it is 2 times the diameter of the femur. Okay. Follow-up, allograft incorporated, and prosthesis stable with heel fracture at 6 months. And also be aware that it will take longer. We are doing in elderly, so it will take longer to incorporate into heal. Case 2. So this is again pre-existing asymptomatic hip. So can you pick up this, how we are thinking about it? It is first question, how this hip is, always thinking that way. And then what the patient is doing, and from the mechanism of injury, we will know the status and everything. So this is fell out of a car sustaining fracture at the tip of the stem. X-ray showed a solid prosthesis. So treatment, DCP plate with screws, circular wires, follow-up, healed, asymptomatic at 3 years. 3, fractured distal, which is C, okay? 72-year-old male with hip replacement for arthritis, X-ray from routine annual follow-up, 6 months prior to fracture. No problem, I don't see anything. Then boom, okay? Stress rising, You see, over here, if he showed you like this, okay, and he said, okay, that's it, but this patient fell and had a fracture below the stem. Your next question, okay, does he have any fixation down in the distal femur around the knee? And then the question goes that, oh, okay, he knows, okay, and he will show you this. Yeah, he has a total knee replacement. So how are we going to manage this? What's the first step? Okay, I need to know from the history, how was the hip pre-injury? What's the status of this pre-injury? Okay, so this is how you think about it and you build your case. And believe me, once the consultant, once the examiner feel that you are talking very confident, you know what you are talking about, you are assessing everything, you are thinking holistically, then he will relax and then already the mark in his mind. Okay, so this is what they did. And if you notice over here, they spanned both implants, but for this, I will put it up to greater to counter even. Healed at 6 months, 90-year-old with asymptomatic hemi arthroplasty at annual follow-up. So think about what is the classification of the hemi, which is EEF. 2 months later, table prosthesis, so fixation, curved, locked plate with unicortical screw chosen for treatment. But I'm telling you, unicortical screw should not be your first choice. It should be bicortical around the implants. If you cannot, then you put the unicortical screws. Okay. That's why it failed again. Anybody figured out why it failed again? Because this is fracture at the tip. This is what I told you about. It will fail. Okay. Salvage with proximal femur replacement. What they could do from the beginning, they could put strut graft. They can think differently about these fractures. They will need bone graft. They will need good alignment. They will need compression at this side, so it will not be like this or end like that. Conclusion, surgeon must carefully evaluate stability of the implant. Loose fixation implants will allow motion at the fracture site that interferes with healing and gets in the way of more stable fixation device. Loose prosthesis implants will be painful and also interfere with adequate fixation. If the prosthesis or implant is loose or bone quality is poor, then the implant should be revised while fixing the fracture. If the prosthesis or implant is stable and bone quality is adequate for fixation, then the implant should be retained while the fracture is fixed, following standard principles. And remember, if fixation is chosen, follow principles of good fracture care. These are some review articles. If we are still recording, you can find it. And these are selected references. Thank you.
Thank you, Sam. Very difficult and complex topic to talk about. You've handled it quite well, quite comprehensively, and highlighted some of the pitfalls. Just a reminder to you guys, in the very beginning, Sam said that within this exam format, you are a safe DGH consultant. There's no scope for being a hero here, okay? Remember, there's a lovely get out clause in this beginning where you start the sentence where this is a difficult fracture pattern to deal with on a periprosthetic. This is after establishing the history and examination and this, what this patient requires. I would discuss this with my tertiary center for revision hip surgery to consider this, because this will require an off-the-shelf, a number of off-the-shelf equipment that would not be normally available at my at a DGH hospital. And having said this, the principles are, that's it. And then you can go down the line of, I would do the history, the examination, was there any issues with the prosthesis before and after, and so on and so on, down that line. But try and throw that line in. That actually demonstrates your safety and your understanding of how you work within your limitations. Okay, any questions, anyone?
Actually, the question is answered over here. as we said, for B2 fracture and B1 fracture, yes, it can, but as one just said, you are a safe surgeon. You don't want to say B2, you can see it, but what if you decided this is B1 and you went and then intraoperatively you found it B2? You have to be ready. And if you didn't say so, sorry, you are not a safe surgeon, because what you're going to do? These are very complex. You need to discuss with someone who's expert if you are not the one. And if you are the one, you have to have everything. Easy. It's simple. So don't go into this debate. Can I, cannot? Or, yes, maybe I will have this feeling. I will do my CT, but I want to be ready. If I'm performing something, periprosthetic fracture, I have to be ready. I'm operating on frail patients, and I have most of the time one chance. That's it.
Thank you. Any other burning questions?
Yeah, there is a next question about what is the best way to explain why the tip is interfering with the healing. Okay, so AO, go back. Principles, basics. If I have a transverse fracture or short oblique fracture, then I have less surface area for healing, not like the long oblique. Yes, I can have more stable for axial stability, if I did good compression, or if I'm putting IM nail, then yes, maybe some people say you just put interlocking maybe in one, either put your proximal, you don't have to put your distal, or at least you don't have, one screw is enough, because transverse will be stable and will compress each other. But if you are having already the bone is affected, already there is a problem with the bone biology, and you are not compressing, because I said at the beginning, you are trying to just reduce it as much as you can. And you are doing many opening, not big opening. You are putting your plate and you are not compressing that much. All these factors can make the plate actually the delayed healing. And if we are talking, this is for healing for the question.
Really sorry to cut you off. I do appreciate it. It's just I don't want to be cutting mid sentence for you. Thank you very much, everyone. We'll come back in 5 minutes. I'll send out another invite. We'll do the hot seat. I notice we've got quite a few of our mentor groups.